TV.
From Kampala Serena Conference Center, I'm Andrew Chamagero Muntu. Now, for the past 2 weeks, the debate amongst the legislators are focused on the supplementary fund worth 18.5 billion Ugandan shilling for acquiring COVID-19 vaccine. However, during these times, the number of COVID-19 patients in Uganda, according to Ministry of Health, is going on the low. It's dropping. To clarify more on this phenomenon, COVID-19 reducing numbers, we have Dr. Monica Musenero, the Presidential Advisor on Epidemics. Good morning, Doctor.
Good morning.
It's an honor to have you this early morning. Now, Doctor, nearly 2 months ago, there was a warning that Uganda was heading in phase 4 of the virus spreading. Then the number of infections has started to drop. What is going on?
Thank you very much, and thank you for having me. We have noticed globally, not just in Uganda, we have noticed globally that over the past number of weeks, especially starting in mid-January, in many countries, there's been a drop. There's been a steady drop in the number of cases, and the World Health Organization yesterday issued a statement. So when you look at the epidemic curves of such diseases, there are those peaks and then it goes down, because usually when it goes up, people become very alert. There is a lot of awareness and response to the information, and people begin to feel it's real. So a combination of factors will result into a drop. Whether it is going to go up again, we don't know.
Okay.
Yes.
So, Doctor, did we go in phase 4?
This is not only in Uganda. Globally, we are seeing a drop in daily cases.
Okay. Doctor, does this mean among those issues that could possibly have contributed to the drop is the cost of testing is one of those, because some Ugandans would choose not to come to be tested because, you know, it's very expensive in Uganda anyway?
Well, that could be a factor, but if it was a factor, then it would be only in Uganda. If it was only Uganda, then we would know that it is just testing. But this is happening on a wider scale. When you look at the global curve, there is, of course, they are in countries where they are vaccinating, but also I think people felt like they can comply a little bit better because seems to be time limited. The vaccine is coming. In many countries, we have seen that. In Uganda, we are thinking about many reasons, that being one of them. But the paying for testing was introduced some time ago, and we have repeatedly said that anybody who is sick can access the test for free. And testing was taken closer to people at health center force. So yes, we have seen a fewer number of people showing up for testing. The majority of them are people needing travel, but also the positivity rate has dropped. So it's a bigger phenomenon than just Uganda charging for testing.
Okay. Dr. Musenero, we have not had a recent nationwide test in the country. When will this happen to determine the actual infection in the country, or dispel the myth of COVID doesn't exist, especially to the Wanayenches in the villages?
Now, in an epidemic like this, which is so widespread, we don't aim at testing everybody. We use indicative tests. Once we have sampled, we are able to tell how bad the situation is in the country. Of course, it is important for people to test for their case management, And that's why we educate people so that you can go and be tested. When we have always said that the epidemic moves in phases. So now that we are in phase 4, we have been in phase 4. The phenomenon we are seeing, we now need to examine, or possibly over this week and next week, to examine if this is for real. Then we may have to move the phase back to phase 3 or phase 2 and restructure the response. So the amount of testing we are going to do, the nature of testing will depend on which phase now we see we are in the epidemic. So the level of testing and the actions we take on positive individuals change in which phase. So we couldn't fall back to phase 3 of the epidemic. And then there we know the control measures are different and the level of testing changes also, and the objectives for testing change.
Okay. So, Doctor, what informs your decisions on where the hotspots are? We need to understand these. We know that during the campaigns, we are stopping activity, even in areas where there are just 20 people. Now, so here we are. So when do you get to know that this is a hotspot?
It depends on what we call positivity rates. When you collect specimen, for example, when we were in phase 4, we left people because the aim was to find only the sick people, very sick people, and treat them and then guide the others for home care. But should we determine that we need to fall back to phase 3, then we need to be more proactive in testing, because now we know that we can contain small clusters, because there we will be moving to containing the disease in small spaces. We are usually alerted by the positivity rates from the different districts. When people are sick and they go to the hospital, we take their data and we know. If I find that in a small village, I got 5 positive people, then I know that there is a cluster there. So we take there are indicators which show us, and we design the response. We design that if there's a cluster in this area, then we go there and, for example, if we find that in a small village, then we might choose to test most of the people who are very close there to those people, and that will give us an indicator. And then based on what we find out, we'll decide what to do in that community.
Okay. Doctor, now learners are returning to school. Have you determined the risk of infection, that it's declining? Then what is the science behind government's latest move to release candidates or students in bits?
You know that social distancing is one of the key things about control of COVID. When people have lesser chances to be very close to each other, then we have fewer chances of transmitting the virus from one person to the other. Our carrying capacity of 18 million Ugandans in school given the classroom numbers we have, we know that we cannot achieve the minimum space which will minimize infection. It will not totally prevent, but it will minimize infection. So the logic is that we can achieve a minimum, an optimum level of transmission, which we will just minimize so that we are not overwhelmed. Then the second thing is that once you send children to school, they will keep mixing, and the children themselves don't fall very sick, but they fall quite sick, but they are not. Their chance of dying from the disease is quite low. However, children, we consider them vectors. They can transmit the virus to their parents. So we are trying to manage the level of infection that will occur in the community, especially considering that the majority of our children are day scholars. When they are day scholars in the villages, we will be checking to see what is happening. So the severe disease which we are fearing, which we are trying to manage, is not in the children. It is in the homesteads. So by releasing half the children at any one time, we want half the classes until we have vaccinated. When we vaccinate, then we will know that we have another barrier. There's been a lot of talk about kindergarten. It's not that the kindergarten is not important as an education level. It's just that if you have a child, if you have nursery kids in your home, you notice that the home will never be free of flu. Children transmit respiratory infections very, very efficiently. All of you in those homes when you have kindergarten children, because children are intimate. The ones below 6, they are very intimate. They run, they come, they sit on everybody, grandmother and what. So for now, until we get vaccination for the vulnerable groups, we have requested that parents look after their children at home, while once we get the vaccination and we vaccinate the vulnerable groups, those children can go to school.
Okay. Doctor, let's talk about the vaccination programs. You alluded earlier on that vaccination is very key here. How is the vaccination going? When do we expect to get the line for a jab on the arm? Will it be free for starters? If it's going to be paid for, how much should I save enough so that I get the jab?
There are three lines of which have been planned. The first line is there is an international coalition called the COVAX, which is led by the World Health Organization. Through COVAX, which Uganda is a member, COVAX is supposed to give some kind of equity on how we access. So COVAX has assigned Uganda some vaccines, which we expect to get either late this month or early next month. Those vaccines, which are not many, be given to the very highly vulnerable groups. And COVAX has a plan how they will be availing vaccine to Uganda. These vaccines are sourced from various sources, and funding was mobilized internationally. So Uganda submitted our application as part of that COVAX facility. However, to facilitate the speeding up, because Uganda plans to, or has prioritized 9 million people that need to be vaccinated in various tiers. We have those who are vulnerable by age, we have those who are vulnerable by profession, we have those who are vulnerable because they have an underlying disease. So we are going to, they have tiered that, those numbers have been calculated, and for us to do the vaccination and protect the country from death, from COVID, we need to vaccinate a total of 9 million. But that will go by prioritization. They are the very highly vulnerable. We'll go like that with tiers. So in that one, the government plans to buy additional vaccine directly to the manufacturers. So that's the second level. Those two are going to be free. They are planned to be free. Now, there is a private sector who are requesting to purchase vaccines. The policy of government is they should wait until other Ugandans who cannot afford can also access vaccine. So we cannot just say, oh, those who can buy, you buy and get vaccinated, and the poor who can't afford should not be. So it's all going to go by equity. So if all goes well, within March, the vaccines have arrived in the first batch, then the first top vulnerable individuals should be getting the jab.
Okay, doctor, this is my final question. What is your advice to anti-vaxxers, people who just don't want to be vaccinated? What's your advice about the pandemic?
We have two types of antivaxxers. We have individuals who have just been misled, and because they don't know, my advice is they should seek to get information, to get the correct information. And once they have got the correct information, then they can make a decision. Vaccination is a public health issue because anybody who falls sick with a disease like this, it is not only you who is affected, you're also affecting other people. You're affecting the rest of the population. So the anti-vaxxers who have been made anti-vaxxers just because they need information, we are available to provide this information. Just reach us and we'll be able to explain to you what you need. But then there are those anti-vaxxers who have been conspiracy theorists from the beginning. They are always positioning themselves to sabotage everything. I think those ones will deal with them because public health is a legal issue. So anybody who is committing themselves to deliberately and knowingly spread fake information about vaccines, that one we have the Public Health Act to deal with them. So anybody needing information, please, my number is public. The Ministry of Health has numbers. Some of them are toll-free. We have so many platforms. Ask and we'll be able to give you the right information. We have used vaccines a lot, and I don't think that anybody would wait for these particular vaccines to kill Ugandans. So the scientific committee, we really examine every information about these vaccines. So to give you assurance, and actually, Kamara, the vaccine is going to be so rare in the next few months that it is a privilege to have access to it.
Thank you so much. That is Dr. Monica Msenero, the Presidential Advisor on Epidemics. Thank you.